Okay, let's unpack this. We're about to embark on a serious deep dive into a very specific and incredibly important area of cancer biology.
Absolutely, and it's one that sometimes flies under the radar a bit.
Exactly. While these cancers might be relatively rare overall, they hold immense significance, especially when we look at certain populations. We're talking about sarcomas and bone metastases.
Right.
Think of this deep dive as your opportunity to go beyond the surface, to really dig into the details and concepts that distinguish these tumors so you can understand them like the elite professionals in this field.
Exactly. And it's crucial to understand why they are distinct. Sarcomas are mesenchymal neoplasms.
Okay, mesenchymal. What does that mean in practice?
It means they arise from connective tissues, things like bone, muscle, fat, tendons, blood vessels, and nerves throughout the body.
Got it. So not the lining tissues.
Precisely. This is fundamentally different from the vast majority of cancers like breast, lung, or colon cancer, which are epithelial, arising from those lining tissues of organs.
That distinction is key right from the start. And while sarcomas make up less than 1% of all adult malignancies, that overall number doesn't tell the whole story, does it?
Not at all. They are surprisingly common and critical in specific age groups.
Affecting everyone.
Pretty much. They affect people across the entire age spectrum, from infants to the elderly. But when you look at children under 15 years old, sarcomas account for a significant 15% of all their cancers.
15% in kids. Wow.
And perhaps most strikingly, they are one of the most common solid tumors of childhood and the fifth leading cause of cancer death in children.
Fifth leading cause of cancer death in kids. That is a sobering statistic that really underscores their aggressive nature in that population.
It really does. That makes understanding them absolutely vital, despite their overall rarity in the broader cancer landscape.
So our mission here is to go deep into the source material, Chapter 91, which is packed with detailed information on soft tissue and bone sarcomas and tumors that metastasize to bone.
Right, a really dense source.
Our aim is to extract and understand every concept, every detail presented, so you can truly master this complex topic.
This isn't about skimming. It's about building a robust understanding. Whether you're looking to solidify your knowledge for a specific purpose, or you're simply driven by curiosity to understand these unique conditions.
Diving into their distinct origins, behaviors, diagnostic clues, and treatment approaches is essential. Let's start by laying the foundation.
Good idea.
All right, let's define our territory. Sarcomas. The lay of the land. We've already established their mesenchymal neoplasms, primarily mesodermal in origin. What does that look like structurally?
Well, mesoderm is one of the main germ layers back in embryonic development, gives rise to all those connective tissues we mentioned.
Okay.
The source notes that a small number of sarcomas can also arise from neuroectoderm, the layer that forms nervous tissue. But the key takeaway remains that they are not epithelial cancers.
Like carcinomas.
Exactly. Not like carcinomas, which form the majority of what most people think of when they hear cancer. That less than 1% incidence figure for all malignancies highlights their relative infrequency compared to carcinomas.
But as you said, that rarity is deceptive when we look at children.
Absolutely. 15% in children under 15 is a significant proportion, and for adults, about 40% of sarcomas occur after the age of 55.
So a broad age range, but hitting those specific groups hard.
Right. That statistic about them being one of the most common childhood solid tumors and the fifth leading cause of cancer death is a critical point that often surprises people and demands our attention.
So they hit kids hard. How are sarcomas typically broken down into main categories?
The source divides them into the two main groups we'll focus on. Bone sarcomas arising in the skeleton and soft tissue sarcomas arising in the other connective tissues.
Bone and soft tissue. Makes sense.
Yeah, this fundamental division guides our approach to understanding them further.
Okay, let's start with the soft tissue sarcomas, or STS. What exactly counts as a soft tissue in this context?
The source defines soft tissues pretty broadly. It includes muscles, tendons, fat, adipose tissue, fibrous tissue like fascia and ligaments, synovial tissue, which lines joints and tendon sheaths.
Ah, the joint linings.
Right. Also blood vessels and nerves. So essentially all the non-bony connective and supporting structures of the body.
Got it. Stuff that connects, moves, and cushions us. Where do these STS most commonly appear? Is there a pattern?
There definitely is. Roughly 60% of soft tissue sarcomas occur in the extremities, the arms and legs.
Mostly limbs, okay.
And within the extremities, there's a notable difference. The lower extremities are affected approximately 3 times more often than the upper extremities.
3 times more likely in your leg than your arm. That's a specific geographical preference. Very interesting.
It is. Another significant proportion, about 30%, arises in the trunk.
The main body, yeah.
And of those trunk lesions, around 40% are found in the retroperitoneum.
That space behind the abdominal cavity.
Exactly. Where you have the kidneys, pancreas, major vessels.
Right.
It's a tricky spot surgically.
I bet. And the rest.
The remaining 10% occur in the head and neck region. So while they can technically appear anywhere soft tissue exists, the extremities, retroperitoneum, and trunk are the most frequent locations.
What about the sheer numbers, the incidence for soft tissue sarcomas?
The source provided an incidence figure of approximately 13,130 new cases in 2019.
Okay.
That gives a snapshot of how many individuals are diagnosed with STS each year in the U.S., according to that data.
Now let's talk about what might cause these. Are there clear risk factors or specific origins identified in the source?
The source details several potential contributing factors. First, it clarifies an important point. Malignant transformation of a benign soft tissue tumor is actually very rare.
Okay, so most benign lumps stay benign. That's reassuring.
Generally, yes. So if you have a common non-cancerous lump like a lipoma, it's highly unlikely to become a sarcoma.
Okay, so my benign lipoma is probably safe. Is there an exception?
Yes, there's a key exception highlighted. Malignant peripheral nerve sheath tumors, or MPNSTs.
Yep.
Right. These are also known as neurofibrosarcomas or malignant schwannomas. These specific tumors can arise from benign neurofibromas,
Okay.
particularly in individuals with neurofibromatosis type 1 or NF1. This links us back to genetics, which we'll definitely need to delve into shortly.
Got it. So benign nerve tumors in the context of a specific genetic syndrome are the main exception to the rarity of benign to malignant transformation in soft tissues. What about environmental exposures?
Trauma or previous injury is considered a rare direct cause. However, sarcomas can arise in areas of chronic irritation or prior tissue damage.
Ah, okay.
Specifically within scar tissue resulting from surgery, burns, previous fractures, or even around foreign bodies that have been implanted.
Like implants or old shrapnel.
Possibly, yeah. Anything causing long-term irritation. The source also lists chemical carcinogens implicated in pathogenesis, including polycyclic hydrocarbons, asbestos, and dioxin.
So it's less about the initial trauma maybe and more about the long-term process of scarring and tissue remodeling in some cases?
That seems to be the idea.
Huh.
What about medical treatments?
Ah, yeah, iatrogenic causes.
This is a critical point, especially in patients who have survived other cancers. Sarcomas can occur in individuals treated with radiation therapy.
Right.
Importantly, this almost always happens within the previously irradiated field.
So right where the radiation was aimed.
Exactly. The source stresses that the risk increases over time following radiation treatment, making long-term surveillance important for these patients.
So prior radiation for one cancer could potentially lead to a sarcoma years later in that area. That's an important consequence to be aware of. Any viruses linked to STS?
The source is very specific here. It mentions Kaposi's sarcoma, which is caused by human herpes virus 8, or HHV8.
Okay, KS and HHV8.
Right. It occurs in specific populations, such as HIV-positive patients, those with classic Kaposi sarcoma, and HIV-negative homosexual men. But the source explicitly states that no other soft tissue sarcomas mentioned there are associated with viruses.
That's a clear distinction then. Kaposi's is the viral outlier in this group.
Definitely. Okay, KS is the exception. What about the immune system?
Good question.
Yes, compromised immune function, whether congenital or acquired, like due to HIV or therapeutic immunosuppression after an organ transplant, does increase the risk of developing soft tissue sarcomas.
Okay, so immunosuppression is a risk factor too. That covers the origins and risk factors. Now let's dig into the genetic underpinnings because the source provides significant detail here, starting with inherited syndromes that predispose individuals.
Absolutely. This is where we see how genetics can significantly increase susceptibility. The first syndrome mentioned is Li-Fraumeni syndrome.
Li-Fraumeni. Heard of that one?
Yeah, it's a familial cancer syndrome caused by inherited germline abnormalities in the p53 gene.
Ah, the famous p53 tumor suppressor.
The very same. It's a critical tumor suppressor gene.
Yeah.
Individuals with this syndrome have a substantially increased risk not only of soft tissue sarcomas, but also a whole range of other malignancies, including breast cancer, osteosarcoma, which is a bone sarcoma, we'll get to that, brain tumors, leukemia, and adrenal cortical carcinoma. It's a dramatic example of how a single genetic defect can predispose to multiple cancer types.
Wow, the P53 gene is a fundamental gatekeeper, and a defect there opens the door to multiple cancers. It's like having a major flaw in the cell's primary defense system.
That's a good way to put it. You also mentioned NF1 earlier.
Yes, neurofibromatosis 1, or NF1.
This is characterized by multiple neurofibromas, those benign nerve sheath tumors we talked about, and characteristic skin findings like cafe au lait spots.
Those coffee-colored spots.
Right. As noted, the malignant degeneration of these neurofibromas into MPNSTs is a significant risk at NF1. The underlying genetic defect is in the NF1 gene located on chromosome 17.
Okay.
This gene encodes a protein called neurofibromin, which functions as a tumor suppressor by specifically inhibiting the function of the RAS protein.
RAS, another key player in cell growth.
Exactly. RAS is a key signaling switch involved in cell growth and division. When neurofibromin is faulty, the RAS switch can get stuck in the on position, driving uncontrolled growth, particularly in nerve sheath cells.
So a faulty gene leads to a faulty protein, which fails to put the brakes on a critical growth pathway, leading to these nerve-associated sarcomas. That makes a mechanism clear. Any other syndromes?
Inherited retinoblastoma is another example.
The eye cancer in kids.
That's the one. It's caused by a germline mutation in the RB1 gene located on chromosome 13q14. Survivors of inherited retinoblastoma are at increased risk later in life, not only for developing osteosarcoma,
which is common after retinoblastoma treatment.
Right, a common secondary cancer, but also for developing soft tissue sarcomas unrelated to any radiation they might have received for the eye tumor.
Oh, interesting. So the RB1 defect itself increases the risk.
It seems so. It demonstrates that the RB1 mutation, another key tumor suppressor, has broader effects beyond just the eye.
So RB1 defect also increases risk for both bone and soft tissue sarcomas years later. Are there other more general familial links?
The source briefly notes that other soft tissue tumors, including some typically benign ones like desmoid tumors, lipomas, and leiomyomas, as well as neuroblastomas and paragangliomas, show occasional familial predisposition.
Suggesting genetics might play a role sometimes even without a named syndrome.
Exactly. Suggesting genetic factors may play a role in some families.
Okay, those are the inherited risks. What about specific genetic alterations found within the tumor cells themselves? Not inherited, but acquired by the tumor.
Right, somatic mutations. This is where we see characteristic chromosomal rearrangements, particularly translocations, where pieces of chromosomes swap places.
Swapping pieces.
A classic example is seen in synovial sarcoma. About 90% of cases have a specific recurrent chromosomal translocation, TX18P11Q11.
X and ancient swapping bits.
Exactly. This translocation fuses parts of the SYT gene on chromosome 18 with one of two SSX genes, SSX1 or SSX2, on the X chromosome, creating a chimeric fusion gene product.
So two genes that weren't supposed to be next to each other get joined up, creating a new abnormal gene.
Precisely. And this fusion gene product is believed to drive the development of synovial sarcoma.
Does it matter which SSX gene is involved?
Apparently, yes. What's even more detailed, the source mentions a prognostic distinction based on which SSX gene is involved. Patients with translocations involving SSX2 may actually have slightly longer survival than those with translocations involving SSX1.
That's deepic. The specific partner in the translocation matters for outcome. That's a subtle point, but it illustrates how specific genetic variants within a single sarcoma subtype can have clinical implications for prognosis.
It really does. What else is mentioned about specific genes or proteins?
Anything else stand out?
The source discusses insulin-like growth factor type 2, or IGF.
Okay.
It notes that some sarcomas produce IGF-2.
Okay.
And this molecule can act as both an autocrine growth factor, stimulating the tumor cell's own growth,
Fueling itself.
and a motility factor, promoting metastatic spread. It drives growth primarily through IGF-I receptors, but surprisingly, its effects on cell movement happen through different receptors entirely.
So it acts like a self-fueling engine and a signal to pack up and move out. That's a dangerous combination.
It really is.
Yeah.
And there's that unusual clinical finding. Large amounts of secreted IGF-2 can lead to hypoglycemia or abnormally low blood sugar levels.
Low blood sugar from a tumor. That's unexpected and highlights how these cancers can disrupt normal body functions in surprising ways. A rare paraneoplastic syndrome.
Exactly. What about broader genomic studies? Anything looking across many patients?
Good question.
The source references a large international study involving over 1,100 sarcoma patients and their families. This study found that about half of sarcoma patients had detectable, putatively pathogenic mono and polygenic variation in cancer-associated genes.
Meaning
They found single gene mutations or combinations of multiple gene variations that were likely contributing to their risk.
so not just one major hit, but sometimes maybe a combination of smaller genetic changes adding up.
Yes, potentially. The study also observed that these patients with genetic variations were diagnosed at an earlier age.
Okay, that makes sense.
And critically, the source points out that some of these genetic variations represent therapeutically actionable targets.
Targets for treatment.
Exactly. Meaning they are pathways or proteins that existing or developing drugs could potentially target. This is where the genetic understanding directly intersects with the potential for personalized medicine in sarcomas.
That's a crucial link, showing how genomic research is identifying new avenues for treatment. It really underscores the value of understanding this complex genetic landscape.
Absolutely. Now, let's move on to classifying soft tissue sarcomas. As you can probably tell, they aren't a single uniform disease.
Right, the source mentions around 20 different groups based on differentiation. How does that work?
Correct. The classification is primarily based on what normal mesenchymal tissue the tumor cells appear to differentiate towards or resemble under the microscope.
So it's like looking at a distorted version of a normal tissue type.
Kind of, yeah. It's like looking at a distorted version of a normal tissue type.
So they look somewhat like fat cells or somewhat like muscle cells.
Exactly. For example, fibrosarcomas show differentiation toward fibroblasts, the cells that make fibrous tissue. Leiomyosarcomas show differentiation towards smooth muscle cells and are characterized by their spindle, elongated shape.
The spindle cells, okay.
Liposarcomas show differentiation towards adipocytes or fat cells.
And if they don't clearly resemble any specific tissue, if they're just kind of a mess,
then they're often classified as unclassified sarcomas or, as we'll see, undifferentiated pleomorphic sarcoma.
okay.
The source also notes that bone sarcomas that arise outside the bone, like an extraskeletal osteosarcoma, are also included in the broad category of soft tissue sarcomas.
You mentioned undifferentiated pleomorphic sarcoma, UPS. The source discusses how the definition of malignant fibrous histiocytoma, or MFH, has evolved. Can you explain that shift? That name used to be really common.
It did. This is an important historical point in sarcoma classification. MFH was a broad category that included tumors previously called fibrosarcomas or other pleomorphic.
Pleomorphic meaning highly variable in appearance.
Exactly, highly variable cells. Pathologically, MFH had a characteristic look, a mix of spindle-shaped cells and rounder, histiocyte-like cells, often arranged in a swirling or storiform pattern.
Storiform, like a pinwheel.
Kind of, yeah. With multinucleated giant cells and marked cellular variability, a real mix.
So it's defined largely by its microscopic pattern.
Yes. But with the widespread use of immunohistochemistry, those special stains that help reveal cellular lineage by detecting specific proteins.
Right, the protein stains.
Pathologists realized that many tumors previously labeled as MFH actually showed features of differentiation towards other lineages, particularly muscle myogenic differentiation.
So they weren't really histiocytic after all.
Not really. Because of this, a large proportion of tumors, formerly called MFH, are now reclassified, often as poorly differentiated leiomyosarcomas. The source explicitly states that the terms undifferentiated pleomorphic sarcoma, UPS, and myxofibrosarcoma have largely replaced MFH and myxoid MFH, respectively.
So MFH isn't really a diagnosis used as often anymore. Those tumors are now recognized as other types, particularly UPS or leiomyosarcoma, based on more precise tests. That clarifies current practice.
Right. This terminology change reflects a deeper understanding of the tumor's true origins. Now, while most soft tissue sarcomas are often grouped together for general treatment strategies, the source highlights that some specific types have distinct features that warrant different considerations.
Like the liposarcoma spectrum you mentioned earlier, they're not all the same.
Exactly. Liposarcomas show a real range of behaviors. The pleomorphic and dedifferentiated subtypes behave like other high-grade aggressive sarcomas.
Okay, the bad actors.
Right. However, well-differentiated liposarcomas, often called atypical lipomatous tumors, are unique because they lack metastatic potential.
No metastatic potential? That's huge.
It is. They can grow locally and be challenging to remove entirely, recurring locally, but they won't spread to distant organs. That's a critical positive distinction.
That's a huge difference. So, knowing the specific subtype of liposarcoma is essential for prognosis and determining treatment intensity. What about the mesenchymal type?
Myxoid liposarcomas are interesting. They metastasize less frequently than high-grade pleomorphic types.
Okay.
But when they do, they have a predilection for unusual metastatic sites that contain fat.
Like where?
These include the retroperitoneum, the mediastinum in the chest, subcutaneous tissue, and even bones, particularly areas with fatty marrow.
Metastasis to bones with fat. That's a detail you wouldn't easily forget. The fact that they seek out fatty locations for metastasis is a quite specific and surprising behavior.
It really is. What other subtypes have distinct behaviors?
Any others stand out?
The source notes that rhabdomyosarcomas, sarcomas of skeletal muscle, Ewing sarcoma, which is primarily a bone sarcoma, can arise in soft tissue, we'll get back to that, and other small cell sarcomas tend to be more aggressive and fast-growing than many other STS.
Okay. More aggressive.
But they're also notably more responsive to chemotherapy.
Ah, so that's a key difference.
Huge difference. This contrasts with types like leiomyosarcoma or UPS, which are generally less sensitive to chemotherapy.
So more aggressive, but also more treatable with systemic therapy. That's a crucial difference influencing management.
It is. And then we have gastrointestinal stromal tumors, or GISTs.
GISTs, right.
The source gives specific attention to GISTs, emphasizing that they are now considered a distinct entity within soft tissue sarcomas, correcting their previous misclassification as gastrointestinal leiomyosarcomas.
So they have their own category now. Where do they originate in the digestive tract?
Their cell of origin is believed to resemble the interstitial cells of Kettle.
The pacemaker cells.
Exactly. These are fascinating cells found in the wall of the digestive tract that act like the pacemakers controlling peristalsis, the rhythmic muscle contractions that move food along.
The gut's pacemakers, that's a great way to think of it. And their molecular drivers are really important for how they're treated, right?
Absolutely. This is where targeted therapy really shines. The majority of malignant Grech yeasts are driven by activating mutations in the c-KIT gene.
c-KIT.
This gene encodes a receptor tyrosine kinase called KIT. The mutation causes this receptor to be constitutively active, essentially. The on switch for growth signaling is permanently engaged without needing the normal signal molecule or ligand.
So the cell gets a constant gray signal, just keeps dividing.
Exactly.
Yeah.
The source also notes that about 5–10% of GISTs have activating mutations in the PDGFRA gene, which codes for another receptor, tyrosine kinase, platelet-derived growth factor receptor alpha.
Okay, PDGFRA.
And for the remaining GISTs that are wild type, meaning they don't have the typical KIT or PDGFRA mutation.
What drives them?
The source suggests they may be driven by mutations in SDHB, C, or D genes, or potentially by the IGF-I pathway, which is related to the IGF-2 we discussed earlier.
This molecular detail is crucial because it directly informs the use of targeted therapies for GIST, which have really revolutionized their treatment.
Indeed. It's a prime example of personalized medicine. Now let's talk about how we diagnose soft tissue sarcomas. What are the clues? How do they show up?
The source says the most common presentation is simply an asymptomatic mass, a lump that doesn't hurt.
Yes. Often that's exactly it. Patients might discover it themselves, or it might be found incidentally on imaging for something else.
And then symptoms come later.
As the tumor grows, mechanical symptoms like pain due to pressure or nerve entrapment or limitations in movement can develop. But often, it starts as a silent lump.
How do you confirm it's a sarcoma and not something benign? You can't just feel it, right?
Absolutely not. The source is emphatic. All new, persistent, or growing masses should be biopsied. You cannot reliably distinguish a benign lesion from a sarcoma just by feeling it or looking at it.
So biopsy is mandatory for a persistent lump. What kind of biopsy is recommended?
Either a small incision biopsy or, more commonly now, a core needle biopsy.
Okay.
And a crucial practical point, stressed, is that the placement of the biopsy incision is absolutely vital.
Why is that so important?
It must be positioned so that the biopsy site and the entire needle tract can be completely removed later during the definitive surgical excision without complicating the surgery or compromising the ability to obtain clear margins.
Ah, so you have to plan ahead for the big surgery.
Exactly. A poorly placed biopsy can make subsequent limb-sparing surgery much more difficult or even impossible. It can seed tumor cells along the track.
That makes perfect sense. The diagnostic step shouldn't interfere with the curative treatment step. Once diagnosed, where do STS tend to spread? Metastasis patterns?
The most common site for distant metastasis is the pulmonary parenchyma, the lungs. That's true for most sarcomas.
Lungs, okay.
However, we've touched on this, but it's worth repeating the exceptions to the general rules because they're important.
Like lymph node spread, I thought that was rare for sarcomas compared to carcinoma.
It is, overall. Lymph node metastases occur in only about 5% of STS patients in total. However, the source specifically lists subtypes with a significantly higher incidence of nodal spread, around 17%.
Which ones are those?
These are synovial sarcoma, epithelioid sarcoma, clear cell sarcoma, sometimes confusingly called melanoma of the soft parts, because it shares some features with melanoma.
Melanoma of the soft parts. Okay.
Your angiosarcoma and rhabdomyosarcoma. For these specific types, checking the lymph nodes is much more important.
So nodal spread is uncommon unless it's one of the specific exceptions. Good to know. What about other distant spread patterns besides the lungs? Any other quirks?
As we mentioned, GSTs tend to metastasize to the liver, often sparing the lungs initially.
GS to liver. Got it.
Mucoid liposarcomas have that unusual predilection for fatty sites, including bone. Clear cell sarcomas may also spread to bones, and alveolar soft part sarcoma is noted as one of the rare types that can metastasize to the central nervous system.
Lots of specific behaviors depending on the subtype. It really matters what kind it is. How is imaging used in diagnosis and staging?
Imaging is essential, absolutely. For evaluating the primary tumor, the best modality depends on its location.
Like MRI versus CT.
Exactly. Plain radiographs and MRI are preferred for tumors in the extremities and head and neck. CT scans are generally better for tumors in the chest, abdomen, and retroperitoneum.
What kind of information do these provide differently?
MRI excels at showing the extent of the tumor within soft tissues and, crucially, within the bone marrow if it's near bone. It gives great soft tissue contrast.
Okay. And CT?
CT is better at detailing bone destruction if the tumor involves bone or detecting calcification within the tumor mass itself.
And for looking for spread, metastases?
To look for metastases, a chest radiograph and especially a CT scan of the chest are standard for detecting lung metastases, the most common site. Other imaging studies might be performed based on specific symptoms, physical exam findings, or the known behavior of certain histologic subtypes, like maybe a liver scan for GOX.
Okay, so imaging helps us see the tumor and potential spread. How do we stage STS and determine prognosis? What predicts outcome?
The two most important prognostic factors identified in the source are the histologic grade of the tumor.
How aggressive it looks under the microscope.
Right, reflecting its growth rate and likelihood to spread, and the size of the primary tumor. Bigger is generally worse.
Grade and size. Makes sense. And the staging system, is it TNM?
Yes, the current American Joint Committee on Cancer, or AJC, staging system is used. The source outlines its components. T stands for tumor size.
How big?
T1 is 5 centimeters or less. T2 is greater than 5 centimeters up to 10 centimeters. T3 is greater than 10 centimeters up to 15 centimeters. And T4 is greater than 15 centimeters. So size matters a lot.
Okay, T1 to T4 based on size. What about NMG?
N is for regional lymph nodes. N0 means no regional lymph node metastases, and N1 means regional lymph node metastases are present. M is for distant metastasis. N0 means no distant metastases, and M1 means distant metastases are present.
And G for grade.
G is for grade. G1 is low grade, and G2 and G3 are high grade. These factors are combined in the AJCC system to define stages ranging from stage I, generally smaller, low-grade tumors without spread, to stage 4, any tumor with distant metastasis or regional lymph node metastasis.
So it combines how big it is, how aggressive it looks under the microscope, and whether it has spread regionally or distantly. How does that relate to prognosis?
Prognosis is directly linked to the stage. The source indicates that cure is common when there is no evidence of metastatic disease at diagnosis, stages I and III.
That's good news for localized disease.
Yes, and encouragingly, cure is still considered possible even in a small number of patients who present with a limited amount of metastatic disease, some stage 4.
Really? Even with some spread?
Yes, if it's limited, maybe just a few lung nodules that can be surgically removed, cure is sometimes achievable.
Okay. What about widespread disease?
For patients with advanced widespread metastatic disease, the historical median survival mentioned is around 13-14 months with multiple lines of therapy. However, the source adds that some patients can live for many years with stable or slowly progressive disease, which is a crucial point of hope for those with advanced illness. It's not always a rapid decline.
It's good to know that an advanced stage doesn't necessarily mean a rapid decline for everyone. Some patients can have a more indolent course, even with spread. So, with this staging in mind, how do we treat soft tissue sarcomas? What's the approach?
It's typically a multimodal approach, meaning we use a combination of therapies tailored to the stage and subtype. The general approach follows the AJCC staging.
Give us the breakdown by stage.
Okay. For stage 1, surgery alone is often sufficient.
Just cut it out.
Pretty much, if you get clean margins. For stage 2, surgery combined with adjuvant radiation therapy is common to improve local control.
Surgery plus radiation.
Right. For stage 3, which often involves larger and/or higher-grade tumors without distant spread, surgery is the mainstay, and neoadjuvant before surgery or adjuvant after surgery, chemotherapy may be added, often along with radiation. It gets more complex.
So chemo might come into play for stage 3 and stage 4.
For stage 4, with metastatic disease, the focus is primarily on systemic therapy, chemotherapy, or targeted drugs, although surgery or radiation may be used for specific metastatic sites to control symptoms or remove limited disease.
Okay, makes sense. Let's talk about the surgery for the primary tumor. The source describes something about a pseudocapsule. What's that about?
Yes, this is a key point about the surgical anatomy of soft tissue sarcomas. As the tumor grows, it pushes on and compresses the surrounding normal tissues, creating a layer that looks like a capsule.
A pseudocapsule, a fake capsule.
Exactly. This can be very deceptive during surgery, making the tumor appear well-defined and easy to just shell out or perform a marginal excision just inside this apparent capsule.
And why is that deceptive? Why is shelling it out bad?
Because microscopic tumor cells invariably extend beyond this pseudocapsule into the surrounding tissue. They sneak out. If you only remove the tumor within this false boundary, a marginal excision, the local recurrence rate is extremely high, ranging from 50% to 90%. You're leaving disease behind almost every time.
50 to 90% recurrence, so a much wider margin is needed.
Absolutely. The standard surgical procedure for achieving local control is a wide excision. This means removing the tumor with a margin of surrounding healthy tissue, including the biopsy site and tract,
I get the biopsy tract too.
to ensure all microscopic tumor extensions are removed. The goal is a negative margin, meaning no tumor cells are seen at the edges of the removed tissue under the microscope.
Clean margins are critical. And how has limb-sparing surgery become the norm instead of amputation for many extremity tumors? That seems like a huge advance.
It is a massive advance. This is a direct result of adding adjuvant radiation therapy and/or chemotherapy to the treatment plan.
How do they help?
These therapies are effective at killing the microscopic tumor cells that extend beyond the visible tumor and might otherwise be left behind even with a wide excision. By doing so, they have improved local control rates dramatically, up to 85–90%, making limb-sparing surgery achieve local control rates comparable to what was previously only possible with radical resections or amputations.
That's a massive advancement for patients, preserving function and quality of life. When would amputation still be necessary then?
According to the source, amputation or more radical surgical excision might still be indicated if it's impossible to obtain a tumor-free margin with a limb-sparing approach.
Can't get it all out safely.
Right. Or if the risks of radiation therapy to achieve local control are too high in that specific location, maybe near sensitive nerves.
Okay.
Or if the tumor involves critical neurovascular structures in a way that surgical removal would result in unacceptable loss of limb function anyway.
So limb sparing is the goal when possible, but getting a clean margin and preserving function are the absolute priorities.
What about radiation therapy specifically? How is that used?
External beam radiation therapy is used as an adjuvant therapy alongside limb-sparing surgery, primarily to improve local control rates, to zap any remaining microscopic cells.
Okay. And the timing, before or after surgery.
The source discusses the timing. Radiation can be given before surgery, neoadjuvant, or after surgery, adjuvant.
Are there pros and cons to each timing? Is one better?
Yes, there are trade-offs. Preoperative radiation allows for treatment of a smaller tumor volume, often resulting in smaller radiation fields and lower doses.
Sounds good.
But it can unfortunately increase the rate of wound complications after surgery. Healing can be tougher.
Ah, okay. And post-operative?
Post-operative radiation requires larger fields to cover the entire surgical bed, and often higher doses to account for potential oxygen deprivation in the healing tissue, which makes cells more resistant.
Hypoxia, right. Exactly, hypoxia. But post-op generally results in a lower rate of acute wound complications, though maybe a higher rate of later complications like fibrosis or joint stiffness.
So a trade-off between immediate surgical healing and potential later long-term effects. Makes sense.
Correct. The source also mentions brachytherapy.
Internal radiation.
Yeah, which is a type of internal radiation where radioactive sources are temporarily placed directly into the tumor bed after surgery.
How does that compare?
It's noted as having comparable efficacy to external beam radiation for local control in most cases, except possibly low-grade lesions, and can be less time-consuming and potentially less expensive.
And modern techniques like SBRT, stereotactic.
With the development of stereotactic body radiotherapy, SBRT, the source notes its emerging role in treating oligometastatic disease.
Oligometastatic, meaning just a few mets.
Exactly. That's when a patient has a limited number of metastases in different locations, like maybe 1 or 2 spots in the lungs. SBRT allows for very high doses of radiation delivered precisely to these limited sites.
Okay, high precision radiation for limited spread. Now let's move on to chemotherapy, for which STS subtypes is chemo considered a primary treatment, really essential.
As we touched on, systemic chemotherapy is considered the mainstay of treatment for Ewing's Sarcomas peanuts and rhabdomyosarcomas. These are the sarcomas historically known to be most responsive to chemotherapy drugs.
Right, the ones that are more sensitive. What about the more common non-small cell sarcomas like leiomyosarcoma or UPS? Is the evidence for chemotherapy strong there? Does it help much?
That's been a big question. The source references meta-analyses of clinical trials to address this. A meta-analysis of 14 randomized trials showed that doxorubicin-based chemotherapy resulted in a significant improvement in local control and disease-free survival for STS.
Okay, less recurrence. What about living longer? Overall survival?
The impact on overall survival was smaller but statistically significant, showing about a 4% improvement across all sites and a 7% improvement specifically for extremity STS. So, modest but real.
A modest but real survival benefit. Any updates on that?
Yes. An updated meta-analysis that included trials using combination regimens like doxorubicin plus ifosfamide reported a statistically significant 6% overall survival advantage favoring chemotherapy.
Okay, still modest.
But the source highlights a specific regimen. An anthracycline, like doxorubicin, combined with ifosfamide, requiring growth factor support to manage blood counts.
Doxo plus ifos, a standard combo.
Right. This specific combination showed a significant 19% improvement in overall survival in patients with high-risk soft tissue sarcomas of the extremity.
19%. Now that's substantial. What counts as high risk?
High grade, 5 centimeters or larger, or locally recurrent tumors. For those patients, chemo really seems to make a difference.
A 19% improvement in survival for high-risk extremity tumors is quite substantial. That's where chemo really seems to make a difference.
It is. The source also notes that long-term follow-up of a trial using this doxorubicin-ifosfamide combination in the neoadjuvant setting before surgery confirmed this survival benefit, reporting a 10-year survival rate of 61%.
61% at 10 years is pretty good for high-risk sarcoma.
It is. A more contemporary trial mentioned also confirmed the superiority of this standard anthracycline and ifosfamide regimen compared to histology-tailored chemotherapy approaches for many STS types. So the standard combo holds up.
That solidifies the evidence for that specific combination, especially for high-risk disease or when used before surgery. Now, what about treating advanced or metastatic STS when it's already spread?
Yeah, metastatic soft tissue sarcomas are, unfortunately, largely considered incurable. It's a tough situation.
Bye.
However, the source offers an important note of hope. Up to 20% of patients who achieve a complete response to treatment can become long-term survivors.
20%. So while the odds are against it, cure is not impossible if you get a complete response.
Exactly. So the therapeutic goal isn't always cure, but aiming for complete remission is still important where possible.
Makes sense. How often is complete remission achieved?
Exactly. The therapeutic intent is often to produce a complete remission, while this is achieved with chemotherapy alone in less than 10% of patients.
Not great odds with chemo alone.
No. But the source states that with surgical resection of metastases, a complete remission is achieved in 30–40% of cases. This highlights the integrated nature of treatment.
So surgery for metastases is a key part of trying to achieve that complete response, cutting out the mets.
Yes. The source states that surgical resection of metastases, whenever feasible, is an integral part of management, not just palliative. It also notes that some patients can benefit from repeated surgical excisions of metastases if they recur.
Which chemotherapy drugs are most active in the advanced setting? What are the workhorses?
The two most active agents mentioned are doxorubicin and ifosfamide, the same ones we discussed earlier.
Doxo and ifos again.
Right. The source notes they have a steep dose-response relationship in sarcomas, meaning higher doses, if tolerated, might be more effective.
And if those don't work or patients can't tolerate them, what are the next options? Second line.
Gemcitabine, often combined with docetaxel, is an established second-line regimen. Yeah, Gemtax. It's particularly active in patients with UPS and leiomyosarcomas.
Any other traditional chemo drugs with activity?
Dacarbazine is mentioned as having modest activity. And again, there are agents with selective activity in specific subtypes.
Like
Taxanes, paclitaxel, docetaxel, in angiosarcomas, and vincristine, etoposide, and irinotecan, which are effective in rhabdomyosarcomas and Ewing sarcomas. This again reinforces that specific histology matters even in the metastatic setting.
it really does. Now, this is where the targeted therapies come in, right? Based on those genetic discoveries we talked about.
Precisely. This is a rapidly expanding and exciting area. Several targeted therapies are now approved. Pazopanib. It's approved for patients with advanced soft tissue sarcomas, excluding liposarcomas, after failure of prior chemotherapy.
How does it work?
The source explains its mechanism. It's a multi-targeted receptor, tyrosine kinase inhibitor, blocking signals from VEGF receptors, important for blood vessel growth, PDGF receptors, and c-KIT.
So it hits multiple growth pathways and cuts off blood supply.
Kind of, yeah. Two other drugs, trabectedin and eribulin, which are somewhat chemotherapy-like but with distinct mechanisms, also received approval based on phase 3 trials.
Trabectedin.
Trabectedin was tested against dacarbazine in advanced leiomyosarcomas and liposarcomas that had previously received anthracycline therapy. It significantly improved progression-free survival.
So trabectedin is specifically for leiomyo and liposarcomas after anthracycline.
Got it.
And eribulin.
Eribulin was tested in a similar trial and showed an improvement in overall survival, predominantly in the liposarcoma subgroup.
So eribulin is mainly for liposarcoma.
Because of this, it's approved specifically for patients with advanced liposarcoma after prior therapy. This is another example of subtype-specific efficacy.
Eribulin for liposarcoma noted. What about targeted therapies linked more directly to specific genetic pathways, like the genetics we discussed earlier?
Great question. Tazemetostat, an EZH2 inhibitor, is approved for metastatic epithelioid sarcomas.
Epithelioid sarcoma.
Yes. This is a classic example of a pathway-driven therapy. Epithelioids, sarcomas, are often characterized by the loss of the INI1 tumor suppressor gene.
Loss of INI1.
And this loss leads to abnormal activation of the EZH2 pathway. Tazemetostat blocks this activated pathway.
That's a beautiful example of targeting a specific vulnerability caused by a genetic defect. Very cool.
It is. And finally, we return to imatinib, the GJ's drug.
Right, Gleevec, the original success story.
Absolutely. It targets the KIT and PDGF receptor tyrosine kinases, those on switches we discussed. Imatinib is the standard therapy for advanced or metastatic GISTs.
And another type.
As well as for another soft tissue tumor called dermatofibrosarcoma protuberans, DFSP.
Imatinib was a groundbreaking success story in targeted therapy. Is it used earlier too?
Absolutely. It's also used as adjuvant therapy for completely resected primary GISTs, meaning after surgery, to reduce the risk of recurrence.
How long do you give it after surgery?
That's a key question. The source discusses the duration of adjuvant imatinib, noting that a phase 3 trial showed 3 years of treatment was superior to 1 year for high-risk GISTs.
3 years better than 1.
Although the truly optimal duration remains unknown, so that's still an area of ongoing research.
So even with targeted therapy, questions remain about how long to keep patients on treatment. What happens if a GIST becomes resistant to imatinib? Which happens, right?
It often does eventually. Sunitinib and regorafenib are approved agents for second and third line use, respectively, for patients whose GISTs progress on or who are intolerant of imatinib.
Yeah, a sequence. Imatinib, then sunitinib, then regorafenib.
Generally, yes. Most recently, ripretinib, which inhibits KIT and PDGFRA, including common resistance mutations, was approved for fourth-line use in metastatic GIST, based on improved progression-free and overall survival compared to placebo.
So a clear sequence of targeted therapies is available for GIST as resistance develops. That's good progress.
Yes, and one more highly specific targeted therapy is avapritinib.
Avapritinib.
It's approved for use specifically in the subset of metastatic GISTs that harbor the PDGFRA D842V mutation.
Wow, that's specific.
It is. So if your GST has that exact mutation, avapritinib is indicated. That's personalized medicine taken to a very granular level.
Indeed. That was a thorough look at soft tissue sarcomas, covering their complexity from origin and genetics to diagnosis, staging, and multimodal treatment, including all those targeted agents. Really comprehensive.
Okay, ready to shift gears.
Let's do it. Now, let's shift gears and discuss bone sarcomas, tumors that arise directly from the skeleton itself. How common are primary bone sarcomas compared to STS?
They are even rarer. The source states they represent only about 0.2% of all new malignancies.
0.2%, tiny fraction.
Yeah, with approximately 3,600 new cases per year in the U.S. based on the source's data. However, just like STS, they account for a significant proportion of childhood cancers, about 6.5% of cancers in children under 15.
So again, relatively rare overall, but a much bigger piece of the pie in pediatric oncology. Can bone sarcomas arise from other conditions or treatments? Secondary causes?
Yes, the source discusses secondary bone sarcomas. Similar to STS, they can be induced by radiation therapy, often many years after treatment.
Radiation again?
Yes. They can also arise from the malignant transformation of certain pre-existing benign bone conditions.
Like what?
Examples include the transformation of an enchondroma, a benign cartilage tumor inside bone, into a chondrosarcoma.
Okay.
Or the transformation of fibrous dysplasia, bone infarcts, areas of dead bone, or Paget's disease of bone into an undifferentiated pleomorphic sarcoma, UPS, or an osteosarcoma.
So old bone injuries, chronic conditions like Paget's, or previous radiation can set the stage for a bone sarcoma later? How are bone tumors classified? Benign versus malignant.
The source first distinguishes between benign and malignant bone tumors. It lists common benign types categorized by their apparent tissue origin. Cartilage ones like enchondroma, osteochondroma. Bone ones like osteosteoma, osteoblastoma, fibrous tissue types, vascular types like hemangioma, and those of unknown origin like giant cell tumor. Lots of benign types.
And for the malignant ones, which are the main players, the ones we really need to know.
Before listing the sarcomas, the source clarifies that plasma cell tumors like multiple myeloma are technically the most common malignant tumor overall found in bone because myeloma arises from plasma cells in the bone marrow. However, these are hematopoietic malignancies, blood cancers, and are usually discussed separately.
Okay, so myeloma isn't considered a primary bone sarcoma in the same way.
Correct. The focus here is on the four most common malignant non-hematopoietic bone tumors, which are the true bone sarcomas: osteosarcoma, chondrosarcoma, Ewing sarcoma, and undifferentiated pleomorphic sarcoma, UPS.
Osteo, chondro, Ewing's, and UPS.
Got it. It also lists some rare malignant types: chordoma, arising from notochord remnants often at the ends of the spine; malignant giant cell tumor; adamantinoma, unknown origin, often amphibia; and hemangioendothelioma, vascular origin.
Okay, so osteosarcoma, chondrosarcoma, Ewing's sarcoma, and UPS are our main 4 bone sarcomas to focus on. How are these staged? Is it different from STS?
The source mentions 2 staging systems. First, the Musculoskeletal Tumor Society staging system, which incorporates both tumor grade, Stage I low, Stage 2 high, Stage 3 with regional or distant mets.
Grade matters again.
And its compartmental localization. A, if confined within a bone or muscle compartment. B, if it extends outside. So that's anatomical context.
So where it is located within the limb or bone matters for that system, compartment A or B?
Yes. The source then details the T&M staging system for bone sarcomas, which has slightly different categories than STS. T is for tumor size, but the cutoff is different.
How so?
T1 is 8 centimeters or less in size, T2 is greater than 8 centimeters, and T3 indicates discontinuous tumors in the same bone, like skip lesions.
8 centimeter cutoff, okay. And N and M?
N is for regional lymph nodes, N0 is no regional nodes, N1 is regional nodes, M is for distant metastasis, M0 is no distant mets, M1A is lung metastases only, and M1B is other distant sites, like other bones.
So M1 is split based on lung versus other sites.
Interesting. And G for grade.
G's for grade. G1 and G2 are low grade, and G3 and G4 are high grade, and the source specifically points out that Ewing sarcoma is always considered G4 high grade in this system.
Ewing's always high grade. Got it.
These components are combined.
But with different cutoff points and categories tailored to bone. Let's dive into the specific types, starting with osteosarcoma, the most common primary bone sarcoma.
Correct. Osteosarcoma accounts for almost 45% of all primary bone sarcomas. It's the big one.
What defines it?
Pathologically, its defining characteristic, what makes it an osteosarcoma, is that it's a spindle cell neoplasm that actively produces osteoid. That's the unmineralized matrix that eventually forms bone or produces frank bone.
So it's a cancer that tries to make bone but does it wrong in a malignant way?
Essentially, yes. In terms of who gets it, approximately 60% occur in adolescents and young adults, peaking in the second decade of life, ages 10-19.
Teenagers and young adults mostly. Right, with another 10% in the third decade. Osteosarcomas, seen later in life, in the 5th and 6th decades, are often secondary, related to previous radiation or Paget's disease.
And gender.
There's also a male predominance, with males affected 1.5 to 2 times more often than females.
Where in the skeleton does it usually show up? Any favorite spots?
It has a strong predilection for the metaphyses of long bones, the wide parts near the joints where bone growth is rapid.
Near the growth plates.
Exactly. The most common specific sites are the distal femur, just above the knee, the proximal tibia, just below the knee, and the proximal humerus, the upper arm bone near the shoulder. These are areas of intense growth activity during adolescence.
Makes sense it would arise there. How complex is its classification? Are there subtypes?
It's quite complex. About 75% are considered classic osteosarcomas, which are further divided into osteoblastic, chondroblastic, and fibroblastic subtypes based on how they look under the microscope and what matrix they produce.
Okay, classic types. And the other 25%?
The remaining 25% are classified as variants based on clinical presentation, jaw-to-jaw osteosarcoma, morphology, diangectatic, which is large blood-filled spaces, small cell or epithelioid types, or location within the bone, Kurangi peristele or periostele, which arise from the bone surface rather than inside.
Lots of variations there. How is it diagnosed? What's the workup?
Diagnosis requires putting together the clinical picture, radiographic findings, and pathological examination. Patients typically present with persistent pain and swelling in the affected bone area.
Often mistaken for growing pains.
Exactly. Often initially mistaken for a sports injury or growing pains in younger individuals, which can delay diagnosis sometimes.
What are the classic signs on an X-ray? What should you look for?
Plain radiographs are crucial. Classic findings include a destructive lesion within the bone that looks moth-eaten.
Moth-eaten appearance.
A spiculated periostele reaction, where new bone forms perpendicular to the shaft, creating a striking sunburst appearance.
Sunburst. Heard of that.
And Codman's triangle, which is a triangular area of new bone formed, where the periosteum, the membrane covering the bone, has been lifted away from the cortex by the expanding tumor.
Those radiographic features, moth-eaten, sunburst, Codman's triangle, are often highly suggestive of osteosarcoma. Very distinct visual cues.
They are. What other imaging is used besides X-ray?
MRI, CT.
Yes. CT scans are excellent for defining the extent of bone destruction and seeing any tumor calcification. MRI is superior for evaluating the intramedullary extension of the tumor, how far goes up the bone marrow cavity, and any soft tissue extension outside the bone.
So MRI for soft tissue and marrow, CT for bone detail.
Pretty much. For detecting spread, chest X-ray and chest CT are essential for lung metastases, which is the most common site. Bone scans, or FDG-PE scans, are used to look for metastases in other bone.
Because it often spreads bone to bone.
It can, yes. Almost all osteosarcomas are hypervascular and show high metabolic activity on PT.
And the definitive diagnosis requires tissue, right? A biopsy.
Yes, a pathologic diagnosis is made from a biopsy, either a core needle biopsy or an open surgical biopsy. And again, re-emphasizing that critical practical point.
Biopsy placement.
Exactly. The biopsy incision placement must be planned carefully so that it can be completely removed later during the definitive limb-sparing surgery without compromising the procedure.
What about the grade and prognosis for osteosarcoma? Is it usually aggressive?
Most osteosarcomas are high grade, and the source states that the single most important predictive factor for long-term survival is the patient's response to chemotherapy.
How well the chemo works up front.
Exactly. Assessed after the preoperative treatment. How well the tumor shrinks and is killed by chemotherapy is a strong indicator of outcome. A good response is prognostically favorable.
So the treatment approach must involve chemotherapy up front, neoadjuvant chemo.
Yes, the standard management is a multimodal approach centered around chemotherapy. It involves preoperative or neoadjuvant chemotherapy first.
Then surgery.
Followed by surgical removal of the primary tumor, usually limb-sparing surgery, which the source says is feasible in over 80% of cases.
High rate of limb salvage, good.
And then post-operative or adjuvant chemotherapy to clean up anything left.
What are the main chemo drugs used?
The source lists the most effective drugs, the core four: doxorubicin, ifosfamide, cisplatin, and high-dose methotrexate with leucovorin rescue.
Doxo, EFO, cisplatin, methotrexate, the big guns.
Right. Various combinations of these four drugs have been used and are generally considered equally successful.
And with this combination approach, what kind of survival rates are achieved? How well do patients do?
Long-term survival rates for extremity osteosarcoma with effective multi-agent chemotherapy and surgery now range from 60% to 80%.
60 to 80%. That's a good survival rate for such an aggressive tumor, a huge improvement from the pre-chemo era.
Absolutely. Is radiation therapy used for the primary bone tumor? We use it a lot in STS.
Good question. Is osteosarcoma sensitive to irradiation?
Crucially, the source notes that osteosarcoma is generally radioresistant.
Resistant.
Therefore, radiation therapy has no role in the routine management of the primary osteosarcoma tumor, although it might be used for palliation in certain settings or for unresectable tumors, but not routinely for cure.
So, surgery and chemotherapy are the pillars for osteosarcoma, unlike STS, where radiation is also central for local control. That's a key difference. And you mentioned UPS can be related.
Yes. The source states that undifferentiated pleomorphic sarcoma, UPS, which we discussed in soft tissues, is considered part of the osteosarcoma spectrum when it arises primarily in bone and is typically managed similarly to high-grade osteosarcoma.
Okay. Any newer therapies mentioned for osteosarcoma? Anything beyond the standard chemo?
The source briefly notes that a randomized trial has shown improved progression-free survival with regorafenib, a multi-kinase inhibitor, compared to placebo in patients with advanced osteosarcoma. So some newer options are being explored.
Okay, regorafenib showing some promise. Next up is chondrosarcoma. How common is it relative to osteosarcoma?
Chondrosarcoma is the second most common primary bone sarcoma, making up about 20-25% of cases.
So still significant. What age group does it typically affect, different from osteo?
Very different. Unlike osteosarcoma's peak in adolescence, chondrosarcoma is typically a tumor of adulthood and older age, with peak incidence occurring in the 4th to 6th decades of life.
Middle age and older adults. And location in the skeleton. Where does it like to grow?
It has a predilection for flat bones, particularly the bones of the shoulder and pelvic girdles. However, it can also occur in the diaphyseal regions, the shafts, of long bones.
Flat bones mostly. Can it arise from benign cartilage lesions like turn cancerous?
Yes, it can arise de novo on its own, or as a malignant transformation from a pre-existing benign cartilage tumor, most commonly an enchondroma.
That benign cartilage tumor inside bone?
Right. Or, less often, from the cartilaginous cap of an osteochondroma, a benign bony projection with a cartilage cap.
What's its usual behavior like? Fast or slow?
The source describes its natural history as typically indolent, meaning it's often slow-growing, especially the low-grade variants.
Indolent, okay. And presentation. How do patients notice it?
Patients commonly present with pain and swelling in the affected area. Those symptoms may develop more slowly compared to faster-growing sarcomas, like osteosarcoma.
What are the radiographic clues for chondrosarcoma? What does it look like on X-ray?
Plain radiographs may show a lobular-appearing lesion within the bone, often with characteristic mottled, punctate, or annular, ring-like calcifications within the cartilaginous matrix inside the tumor. Those calcifications are a key feature.
Rings and arcs of calcification.
Exactly. But diagnosis, particularly for low-grade lesions, can be challenging. The source notes it's difficult to distinguish low-grade chondrosarcomas from benign cartilage lesions based on imaging and histology alone.
So it's hard to tell benign from low-grade malignant sometimes.
It can be very hard. Therefore, the clinical history and physical examination are crucial. New onset or worsening pain, signs of inflammation, and a progressive increase in the size of the mass are all features that strongly suggest malignancy, even if the imaging is ambiguous.
So the clinical context, is it hurting now when it didn't before? Is it growing? That really helps the pathologist and radiologist make the call for those low-grade ones.
Exactly. Most chondrosarcomas are classified as classic chondrosarcoma, although there are other subtypes.
And where do they spread if they do? Lungs again.
Like other high-grade sarcomas, high-grade chondrosarcomas can metastasize, primarily to the lungs. Low-grade ones rarely metastasize.
How is chondrosarcoma treated? Is chemotherapy used like an osteosarcoma?
This is a key point of contrast with osteosarcoma and Ewing's. Most chondrosarcomas, especially the classic types, are notably resistant to systemic chemotherapy.
Chemo-resistant, so chemo doesn't work well.
Generally, no, not for the common types. Therefore, the mainstay therapy is surgical resection. Wide excision is crucial.
Just surgery, then.
Pretty much. This includes surgical removal of the primary tumor, any local recurrences, and even pulmonary metastases if they occur and are surgically removable. Surgery is the primary weapon because chemo doesn't work well.
But you mentioned there are exceptions, subtypes that do respond to chemo.
Yes. The source highlights two specific histologic variants that are responsive to systemic chemotherapy and are therefore treated differently than classic chondrosarcoma.
Okay, what are they?
Mesenchymal chondrosarcoma is an aggressive small cell variant. Because of its histology and behavior, it is treated like Ewing sarcoma with multi-agent chemotherapy.
Treated like Ewing's. Okay, and the other?
Dedifferentiated chondrosarcoma is a high-grade variant that contains a component of high-grade spindle cells, like UPS or fibrosarcoma, in addition to the cartilage component. It has a poor prognosis and is managed like a high-grade soft tissue sarcoma, often with chemotherapy regimens similar to those used for UPS.
So it's like a low-grade chondrosarcoma suddenly turned really nasty.
Kind of, yeah. That's a critical nuance. Two specific subtypes with chondrosarcoma in the name are actually treated with chemotherapy because they behave more like Ewing's or high-grade STS.
It is. Finally, let's discuss Ewing sarcoma. How common is it among bone sarcomas?
Ewing sarcoma constitutes about 10-15% of all primary bone sarcomas.
So less common than osteo or chondro, but still significant? And age group. Back to younger patients.
Yes, it's most common in adolescents, with a peak incidence in the second decade of life, similar to osteosarcoma, though it can occur in younger children and occasionally adults.
Location in the bone? Different from osteosarcoma.
Yes, typically different. It typically arises in the diaphyseal region of long bones, the shaft, rather than the ends or metaphyses favored by osteosarcoma. It also has a notable affinity for flat bones like the pelvis, scapula, shoulder blade, and ribs.
Shaft of long bones or flat bones. What are the radiographic clues for Ewing's? Any classic signs?
A classic finding on plain radiograph is an onion peel periosteel reaction.
Onion peel?
Yes, which results from layers of new bone being laid down on the surface of the cortex as the tumor grows irritates the periosteum. There's often a significant soft tissue mass associated with the bone lesion, which is much better visualized on CT or MRI scans.
So onion skin bone reaction, big soft tissue mass. And pathologically, what does it look like under the microscope?
Histologically, it's characterized by sheets of monotonous, small, round cells with dark staining nuclei and scant cytoplasm.
The small, round blue cells.
Exactly, the classic small, round blue cell tumor. The source notes it can be pathologically confused with other small cell malignancies like lymphoma, embryonal rhabdomyosarcoma, or small cell carcinoma.
How is it distinguished then if they all look like small blue cells?
Specific markers and stains are used. The presence of the cell surface glycoprotein P3D32, which is the product of the MYC2 gene, also known as CD99, is a marker characteristic of Ewing sarcoma and other tumors in the Ewing family.
CD99 positive, okay. What are PNETs in this context? You mentioned Ewing family tumors.
Right, PNETs. The source clarifies that PNETs, primitive neuroectodermal tumors, are closely related and include entities like peripheral neuroepithelioma, Askin's tumor, a PNET of the chest wall, and esthesia neuroblastoma. Most PNETs actually arise in soft tissues, though they are genetically related to Ewing's bone sarcoma.
So Ewing's is part of a larger family. Any other pathological clues?
Another characteristic pathological feature mentioned is the presence of glycogen-filled cytoplasm within the tumor cells, which can be detected with a periodic acid Schiff, PAS stain. So PAS-positive glycogen is another clue. So microscopic appearance, CD99 marker, PAS stain help identify it. What about its genetics? Is there a specific mutation?
Yes, Ewing sarcoma is strongly associated with a characteristic chromosomal abnormality, a reciprocal translocation between chromosome 11 and chromosome 22, specifically T11, 22, Q24, Q12.
The 1122 translocation, classic.
Right. This translocation fuses the FLI1 gene from chromosome 11 with the EWS gene from chromosome 22, creating a chimeric EWS FLI1 fusion gene product.
A fusion gene again.
Exactly. While the exact function of this fusion protein is complex and still being studied, it's considered a hallmark of Ewing sarcoma and is believed to drive its development.
A specific fusion gene driving the tumor. What about its aggressiveness? How does it behave?
The source emphasizes that Ewing sarcoma is a very aggressive malignancy and is considered a systemic disease from the outset, even if obvious metastases are not detectable at initial diagnosis. You have to assume microscopic spread.
Systemic from the start. Where does it typically spread?
The common sites of metastasis are the lungs, other bones, and the bone marrow.
Lungs, bone, marrow. Given it's systemic from the start, I assume chemotherapy is a major part of treatment. Absolutely essential.
Absolutely. Systemic chemotherapy is the absolute mainstay of therapy for Ewing sarcoma.
Before or after surgery?
It is typically initiated before surgery or radiation, neoadjuvant chemotherapy, to treat the systemic disease and shrink the primary tumor.
What chemo drugs are used?
The source lists the active drugs used in combination regimens: doxorubicin, cyclophosphamide or ifosfamide, etoposide, vincristine, and dactinomycin, a multi-drug cocktail.
And if it comes back, relapse disease.
For patients who relapse, combinations including topotecan or irinotecan with an alkylating agent are often used.
And what about treating the primary tumor in the bone after the chemo shrinks it?
Local treatment for the primary tumor site is also necessary after or during chemotherapy. This can be surgical resection, usually with limb salvage where feasible.
Or radiation? Is that sensitive?
Or radiation therapy, yes. Ewing sarcoma is relatively radiosensitive, unlike osteosarcoma or classic chondrosarcoma. So radiation is a good option for local control, especially if surgery would be too morbid.
Okay, so chemo first, then surgery or radiation for the primary spot. What's the prognosis for Ewing sarcoma? How do kids do now?
The prognosis has significantly improved with intensive multimodal therapy. The source notes that tumors located in the extremities below the elbow and below the midcalf tend to have a better prognosis, with a 5-year survival rate reaching 80% with effective treatment.
80% survival for some locations? That's great.
And this is a crucial and really encouraging point that sets Ewing's apart. Ewing sarcoma at first presentation is a curable tumor, even in the presence of obvious metastatic disease, particularly in children under 11 years old.
Curable, even with distant metastases in some cases, especially younger kids. That's a significant difference compared to most other advanced sarcomas and cancers, highlighting its unique sensitivity to systemic therapy. Remarkable.
Yes, it's a testament to the effectiveness of intensive chemotherapy regimens developed specifically for this disease.
Yeah.
A real success story in pediatric oncology, relatively speaking.
Okay, that covers the primary bone sarcomas, osteosarcoma, chondrosarcoma, and Ewing's, along with UPS. Really distinct entities. Now, let's turn our attention to tumors that metastasize to bone, which are a very common problem in oncology, quite distinct from primary bone cancers.
This is a critical clinical reality. Bone is an extremely common site for metastasis, particularly for carcinomas.
Not sarcomas spreading to bone, but carcinomas.
Mostly carcinomas, yes. The source lists the most frequent primary cancers that spread to bone: prostate, breast, lung, kidney, bladder, and thyroid cancers.
The common ones.
Right. While lymphomas and sarcomas can also metastasize to bone, the source emphasizes that prostate, breast, and lung cancers alone account for about 80% of all bone metastases.
80% from just those 3 types of cancer? That's huge. And importantly, the source makes the point that metastatic tumors to bone are much more common than primary tumors of bone, right?
That is a fundamental clinical distinction, especially in adults. If you see a tumor in an adult's bone, statistically, it's far more likely to be a metastasis from a primary cancer elsewhere in the body, like lung, breast, prostate, than a primary bone sarcoma.
That's a key takeaway for anyone seeing bone lesions. How do these cancers reach the bone? How do they travel there?
They primarily spread hematogenously, meaning through the bloodstream. Cancer cells break off from the primary tumor, enter the circulation, get carried around.
We find a home in the bone marrow.
Exactly. They lodge in the bone marrow where they can set up secondary colonies. Local invasion from a soft tissue mass adjacent to the bone can also occur, but bloodstream is the main route.
Where in the skeleton do they typically settle? Any preferred locations?
Yes. The source lists the most involved sites in descending order of frequency. The vertebrae, the bones of the spine.
The spine is number 1?
By far. Then the proximal femur, the upper part of the thigh bone near the hip, the pelvis, ribs, sternum, breastbone, the proximal humerus, the upper arm bone near the shoulder, and the skull.
Why those spots?
These sites are often rich in red bone marrow, which is where blood cells are made, and they have significant blood flow, making them fertile ground for circulating tumor cells to land and grow.
Makes sense. What kind of symptoms do bone metastases cause? How do patients know they have them?
They can range from being completely asymptomatic, especially early on, to causing significant problems. The most frequent symptom is pain.
Bone pain? What's it like?
It's typically a gradual onset of localized pain over weeks, often described as dull and aching, and importantly, it's frequently worse at night or with weight bearing. That night, pain is a red flag.
Worse at night. Okay. What else?
Other symptoms include localized swelling, nerve root, or spinal cord compression if the metastases are in the spine.
Leading to
back pain, often radiating down a leg, with numbness, weakness, or even bowel bladder changes. Then there's pathological fracture.
The bone breaks easily.
Right. The bone breaks with minimal or no apparent trauma because it has been weakened by the tumor. Or you can get myelophysis. Myelophysis, replacement of normal bone marrow by tumor cells, leading to anemia, low white blood cell counts, or low platelets showing up on blood tests. And high blood calcium levels, hypercalcemia, can also occur with widespread osteolytic bone-destroying metastases.
That back pain with neurologic symptoms sounds particularly serious. You mentioned nerve compression.
It absolutely is. The source emphasizes that new onset of back pain accompanied by neurologic signs or symptoms is a medical emergency and requires urgent evaluation for spinal cord compression.
Why an emergency?
Prompt diagnosis and treatment, often with radiation or surgery, are necessary to prevent irreversible paralysis. Time is critical.
It's clear that bone metastases can have a major impact on a patient's quality of life. Huge source of problems.
They do. The source notes that they are a major contributor to morbidity and decreased quality of life in cancer patients. Pain, fractures, nerve problems. It's rough.
The source describes two main ways these tumors affect bone: osteolysis and osteogenesis. Bone destruction versus bone formation. Can you explain the difference?
Yes. Cancer cells in the bone can cause either osteolysis, which is bone destruction or breakdown, or osteogenesis, which is the formation of new, abnormal bone, or often a mix of both.
How does the bone destruction, the osteolysis, happen? Do the cancer cells eat the bone?
Not directly. Tumor cells themselves produce substances that directly cause bone resorption, like certain vitamin D-like steroids, prostaglandins, or parathyroid hormone-related peptide, PTHrP.
Okay.
Even more commonly, the tumor cells produce cytokine signaling proteins that induce osteoclast formation and activity. Osteoclasts are the body's own cells responsible for breaking down bone normally.
So the tumor tells the osteoclast, hey, break down this bone here. It tricks the body's own cells.
Exactly. The cancer cells hijack and stimulate the body's bone-resorbing machinery. Osteolytic lesions appear as dark areas or holes in bone on X-rays, representing areas of decreased bone density.
Harder to see sometimes.
Yes, they may not be visible on plain X-ray until they've destroyed more than 1 centimeter or a significant portion of the bone. Osteolytic lesions are more commonly associated with hypercalcemia, because calcium is released from the destroyed bone, and elevated levels of breakdown products like hydroxyproline containing peptides in the urine.
Okay, osteolytic is bone breakdown, often causes high calcium. What about osteogenesis, new bone formation? How does that happen?
This occurs when the tumor cells produce cytokines that activate osteoblasts. Osteoblasts are the body's cells responsible for building new bone.
So the tumor tells the osteoblasts to build bone.
Yes, but it's usually disorganized, abnormal bone. This results in sclerotic or blastic lesions, which appear as areas of increased bone density or whiteness on X-ray.
Blastic mets.
These are typically associated with elevated serum alkaline phosphatase, an enzyme involved in bone formation. If the blastic lesions are very extensive, they can rarely cause hypocalcemia, as calcium is used up to form all that new bone.
So some tumors are like a demolition crew, osteolytic, others are like a faulty construction crew, osteoblastic, and many are a mix.
Precisely. Most metastases induce both processes, and the balance between osteolysis and osteogenesis can shift over time. The source gives classic examples. Metastases from kidney cancer are typically mainly osteolytic, while metastases from prostate cancer are often mainly osteoblastic.
Prostablastic.
Right. And breast cancer metastases can be either rhylytic, blastic, or mixed. It varies.
That's fascinating how the primary cancer type can dictate the pattern of bone involvement. How do you distinguish metastatic lesions from other common bone conditions, like osteoporosis? Especially in older adults, they can both weaken bone.
This is a critical point, particularly for spinal lesions in older women. The source notes that osteoporosis, a common cause of bone weakening, typically preserves the cortical bone, the hard, dense outer shell of the bone. It thins it, but the shell remains intact.
Okay.
In contrast, metastatic cancer usually causes destruction of the cortical bone. So seeing disruption or destruction of the cortical outline on imaging is a key sign that suggests metastasis rather than just osteoporosis.
That's a vital radiological sign for differentiation. Look for cortical destruction. How are bone metastases treated? Is the goal cure?
The treatment approach depends heavily on the underlying primary malignancy and the patient's symptoms and overall prognosis. It's important to remember that some metastatic bone tumors are curable, such as those from certain lymphomas or Hodgkin's disease, particularly in children, or maybe germ cell tumors.
Okay, some are curable, but for most common adult cancers.
However, for many common carcinomas like breast, lung, prostate, treatment of bone metastases is primarily palliative. aiming to relieve pain, prevent fractures, and maintain function and quality of life rather than cure the widespread cancer.
So symptom control is a major goal, pain relief especially.
Yes, absolutely, especially pain relief. Local radiation therapy is a very effective treatment for relieving pain from bone metastases, just treating the painful spot.
What about systemic treatments?
For hormonally responsive primary cancers, such as prostate or breast cancer, systemic hormonal inhibition, for example, anti-androgens for prostate cancer, anti-estrogens for breast cancer, is a cornerstone of treatment and can effectively control bone metastases as part of controlling the overall disease.
Are there other systemic therapies that target the bone directly, besides chemo for the primary?
Yes, bone-seeking radionuclides can be used.
Radioactive drugs that go to bone.
Exactly. These are radioactive substances like strontium-89, samarium-153, and radium-223 that are preferentially taken up by areas of high bone turnover, including many metastases. Once localized in the bone lesions, they deliver radiation directly to the tumor cells.
Killing them from the inside.
Right, killing tumor cells and relieving symptoms, especially pain from multiple sites. Radium-223 has even shown a survival benefit in prostate cancer with bone mets.
Okay. And what about drugs that prevent bone breakdown, the osteoclast inhibitors?
This is a major area of therapy now. Denosumab is a monoclonal antibody that targets and binds to rank ligand,
Rank ligand.
a key molecule that stimulates osteoclast activity. By blocking rank ligand, denosumab effectively inhibits the activity of osteoclasts, reducing bone destruction. It's used to increase bone mineral density and reduce the risk of skeletal events like fractures.
So denosumab stops the signal telling osteoclast to work, and bisphosphonates, they do something similar.
Yes. Bisphosphonates, such as pamidronate or zoledronic acid, are another class of drugs that inhibit bone resorption by osteoclasts. They essentially get incorporated into bone and poison the osteoclast when they try to resorb it.
How effective are they?
They are effective at relieving pain, preserving bone mineral density, and significantly reducing the risk of pathologic fractures and other bone-related complications, particularly in patients with osteolytic metastases from breast cancer and multiple myeloma.
Any monitoring needed?
The source recommends careful monitoring of kidney function, creatinine, and serum electrolytes when using bisphosphonates, as they can affect the kidneys.
Can they prevent METs?
It also mentions that monthly administration of bisphosphonates not only helps prevent bone complications, but may also reduce the incidence of bone metastases developing in women with breast cancer receiving adjuvant therapy.
So these drugs, denosumab and bisphosphonates, essentially help reinforce the bone and counteract the tumor's destructive effects. Vital part of supportive care. What if the bone is severely weakened and at risk of breaking anyway, like the femur?
When a weight-bearing bone, particularly in the femur or spine, is significantly weakened by an expanding metastatic lesion and is at high risk of fracturing or collapsing, especially if it's not responding well to radiation, prophylactic internal fixation is often indicated.
Prophylactic surgery, before it breaks.
Exactly. This involves surgery to insert rods, plates, or screws to stabilize the bone and prevent a pathological fracture from occurring, which can be a devastating complication, causing severe pain and loss of mobility.
Makes sense to fix it before it breaks. And what determines the overall outcome for a patient with bone metastases? How long they live?
The overall prognosis is primarily determined by the aggressiveness and stage of the underlying primary tumor. Bone metastases are usually a sign of widespread disease, so the patient's survival depends mostly on how the primary cancer is managed and responds to systemic therapy.
So the bone met are a sign, but the primary cancer drives the prognosis.
Generally, yes. The source also mentions bone pain being common at the end of life.
Yeah, that's important to address.
Yes, it's highlighted that bone pain is a particularly prevalent and challenging symptom in cancer patients receiving end-of-life care, emphasizing the importance of providing adequate pain relief, including appropriate use of narcotic analgesics. Palliation is key.
And hypercalcemia is a related complication we should remember.
Right, as we discussed, extensive osteolytic bone destruction can lead to high calcium levels in the blood, hypercalcemia, which is another medical emergency requiring specific management. The source notes it's covered elsewhere in the original text, but it's a complication directly linked to the effects of metastases on bone.
Now, before we wrap up, the source included a brief mention of carcinoma of unknown primary, or CUP. How does that fit in with our discussion of sarcomas and bone metastases? Seems a bit different.
It is a bit different, but it's included, I believe, primarily to define the term CUP and clarify how sarcomas relate to it. Carcinoma of unknown primary refers to a malignancy where, despite extensive investigation, the primary site where the cancer originated cannot be identified.
So you find the mets, but not the original tumor.
Exactly. It's a relatively common diagnosis in oncology, unfortunately.
And how do sarcomas fit in? Are they considered CUP if you only find a metastasis?
Generally, no. The source specifically states that most investigators exclude metastatic sarcomas from the CUP category.
Why is that? Why aren't they CUP?
Because even when a primary sarcoma cannot be found, the histology of a metastatic sarcoma is usually distinctive enough it looks like a sarcoma under the microscope.
You can tell it's a sarcoma just by looking at the cells.
Often, yes. And the management guidelines for sarcomas are based more on histology, grade, and stage rather than the specific location of the primary tumor, unlike many carcinomas. So identifying a metastasis as a sarcoma provides enough information to guide treatment according to sarcoma principles.
Even without knowing exactly where it started.
Precisely. Unlike many carcinomas where identifying the primary site, for example lung versus colon versus pancreas, is crucial for choosing the right chemotherapy or targeted therapy.
That's a really useful distinction. It underscores again how unique sarcomas are as a category, even when they present as metastases without a clear point of origin. Their defining characteristics under the microscope and their specific behaviors mean they aren't just thrown into the general unknown primary bucket.
Exactly.
Yeah.
It reinforces everything we've discussed about their distinct mesenchymal nature and specific management pathways.
Wow, we really went deep there. That was a comprehensive tour through Chapter 91. We started by setting the stage, highlighting the rarity of sarcomas overall, but their critical impact, especially in children, and contrasting them fundamentally with epithelial cancers.
We did. We then took a comprehensive look at soft tissue sarcomas, exploring their diverse locations, the implicated risk factors like radiation and specific chemical exposures, and delving into that complex genetic landscape from inherited syndromes like Liefraumeni and NF1,
characteristic translocations in synovial sarcoma, and the crucial molecular drivers in G-STEAT that have paved the way for targeted therapies like imatinib.
We navigated their intricate classification system, understanding the evolution of terms like NFH to UPS, appreciating the spectrum of behavior within types like liposarcoma, noting which ones don't metastasize distantly, and the unusual fatty patterns of those that do.
We covered the crucial steps in diagnosis, emphasizing the necessity and proper placement of a biopsy. Can't stress that enough, detailing the typical and atypical patterns of metastasis, including the specific subtypes that frequently involve lymph nodes, and reviewing the role of different imaging modalities.
We broke down their staging using the AJCC system and how prognosis is tied tightly to grade and size. And we spent significant time on their multimodal treatment, the paramount importance of wide surgical margins to avoid those high local recurrence rates.
Got to get it all out.
The distinct roles of adjuvant radiation and chemotherapy, including specific evidence-backed regimens like doxorubicin and their survival benefits, especially in high-risk cases, and the growing array of approved targeted therapies, particularly for GISTA and specific pathway-driven sarcomas like epithelioid sarcoma with tazemetostat.
Then we pivoted to bone sarcomas, noting their even greater rarity compared to STS, but continued significance, particularly in childhood. We covered their origins, including secondary sarcomas arising from radiation or Paget's, and the nuances of their specific staging systems.
We detailed the four main non-hematopoietic types. Osteosarcoma, the most common primary bone sarcoma, its bone-producing nature, classic radiographic signs like sunburst and Codman's triangle, and its multi-drug chemotherapy backbone being key, with resistance to radiation.
Then chondrosarcoma, an adult tumor, typically indolent and chemo-resistant, making surgery the mainstay, but with specific aggressive variants like mesenchymal and dedifferentiated that are chemosensitive and treated differently.
And Ewing sarcoma, an aggressive adolescent tumor characterized by small, round blue cells, the EWS-FLI1 translocation, high chemotherapy sensitivity making chemo the backbone, and the remarkable feature of being potentially curable even with widespread metastases, especially in younger patients. A unique case.
And finally, we extensively explored tumors metastatic to bone, stressing their high frequency compared to primary bone tumors, identifying the most common primary sources, the big three: prostate, breast, lung.
Explaining the mechanisms of bone destruction, osteolysis via osteoclast activation, and formation, osteogenesis via osteoblast activation, and how primary cancer type influences this pattern, bleibrogus-blastic.
We discussed their symptoms, the emergency of spinal cord compression, and the varied treatment approaches aimed at pain relief, preventing fractures, prophylactic fixation, and targeting the bone remodeling process with agents like denosumab and bisphosphonates, while recognizing that the overall prognosis hinges on the underlying primary cancer.
We truly pulled out and explored every significant concept and detail from that chapter. If you followed along, you now have a deep understanding of these complex and often overlooked cancers.
Absolutely. Understanding the distinctions between soft tissue and bone sarcomas, recognizing the importance of specific histologic subtypes and their unique behaviors, appreciating the role of genetic alterations in driving these tumors and guiding targeted therapies, and grasping the challenges and management of bone metastases from other cancers provides a really solid foundation for mastering this area.
Couldn't agree more. It's a complex field, but breaking it down systematically helps get a handle on it.
So here's a final thought to leave you with. Building on that idea of mastering this field, we discussed how genomic studies are revealing therapeutically actionable targets in sarcomas, going beyond just GIST and epithelioid sarcoma.
Yeah, that international study finding variations in half the patients was striking.
Exactly. So as the cost and accessibility of genomic sequencing continue to improve and research identifies more precise molecular alterations, how might this accelerate the shift towards a future where the classification and treatment of all sarcomas become increasingly driven, not just by where they arise or how they look under the microscope,
but by their unique genetic fingerprints.
Precisely. Leading to even more personalized and hopefully more effective therapies tailored to the specific wiring of each individual tumor. Something to ponder as the field moves forward.